This last talk is going to go over some of the ins and outs of using fluids and vasopressors together to manage shock. By the end of this talk, you should be able to demonstrate how to give fluids and vasopressors and show some concern for the dosing and the method of delivery. And I'm hoping that when you get to the sim lab, you'll be able to simultaneously assess and manage patients that are suffering from different kinds of shock. So we'll start with fluids. Usually you're going to give fluids as a first line rather than jumping to vasopressors just to see if it works. And the big reason for that is because vasopressors might actually be harmful if a patient is really dry. So if you think about a patient that's hypovolemic, they're really behind on fluids, and their blood pressure starts getting a bit soft, the first compensatory reaction that the body is naturally going to do is to increase systemic vascular resistance, right? All their blood vessels are going to clamp down, which is why you get that cold extremities and that sort of pale look sometimes. Now, that increase in systemic vascular resistance is the mechanism of action for most vasopressors. So if somebody's just really dry, they're really clamped down, and you add vasopressors to that, you're probably not really doing anything. And if you push that systemic vascular resistance beyond what is the normal sort of physiologic mechanism, the worry is that you might actually reduce perfusion out to the distal tissues. So you might fix their blood pressure, but you might actually make their shock worse. So start with fluids, vasopressors if that doesn't work. Now, how much fluid you give very much depends on the type of shock that you think you're dealing with. So if somebody's hypovolemic and the problem is an empty tank, you just got to give as much fluid as it takes to fill up the tank. But if somebody's in cardiogenic shock, you wouldn't want to give them too much fluid because you might just push them into fluid overload and cause pulmonary edema. The usual approach is you try giving a little bit of fluid and you see what happens. So if they respond well, you can probably give a little bit more. And if the patient doesn't respond after a good trial of fluids, then you're going to use vasopressors. And usually what we'll do is give boluses of fluids in sort of defined increments. So you'll give 500 or 1,000 cc's of fluid. You'll see what happens. If that doesn't work, give another 500, give another 1,000, and then see what happens there. You need to keep in mind that it might take a good 2 or 3 liters before you see a convincing response. So sometimes you do have to sort of sit on this and give quite a bit of fluid before you decide to jump ship and move on to vasopressors. Now, we know fluids can also be harmful if you give too much, so you do have to be cautious about the volumes. And we know specifically it can be harmful in pulmonary edema, which you've already mentioned, and then also cases where the patient might be bleeding. Why this is worse in bleeding is a little bit complicated, but I think you can just think of it as fluids diluting the clotting factors so that the clotting factors aren't able to do their job. And if that happens, then that worsens their bleeding. And I think you've all seen sort of evidence of hemodilution, right? In a patient that came into Emerge last night, they got a whole bunch of fluid because they were sick, and now you're repeating their hemoglobin in the morning and it's down 10 points. That same thing is going to happen with clotting factors and with platelets and everything else that stops bleeding. And if somebody's really bleeding badly, you want all of those clotting factors working as well as they possibly can. So if a patient is bleeding, instead of using IV fluids, you should be using IV blood products and pushing that in. Now, that said, getting blood products immediately when a patient's really sick is sometimes easier said than done. So unless you're working at a big major tertiary center, you're probably still going to give at least like a little bit of fluid. You just want to try and limit the amount that you give. Now, if a patient is bleeding and they're hypotensive together, you should be prepared to give a lot of blood. You're probably used to giving transfusions of 1 or 2 units at a time, but somebody who's actually lost their blood pressure because of hemorrhage, that's a person that's going to need like at least 4 to 6 units of blood. And if somebody's hypotensive and you think the mechanism is bleeding, you should be activating the massive transfusion protocol if that's something that's available at your hospital. When somebody's really sick, you'll want to get the fluid in quickly, and usually that means using a large bore IV and pushing it in with some sort of pressure device. A large bore IV is at least an 18 gauge needle, and you can recognize those ones because the 18 gauge IVs are the ones that have the green hub on the end instead of pink or blue or yellow. Pressure just means squeezing the bag somehow, and there's a bunch of different products that are available to do that. Some of them look like blood pressure cuffs that wrap around the bag and have a little bulb that you can pump. And some of them are really fancy, and they're like a plastic pressure chamber that the bag sort of sits in. But it doesn't really matter. You use whatever you've got. And if you don't have anything, you can just assign somebody to grab the bag and squeeze it with their hands, and that really works just as well as anything else. Pressure and the size of the IV really do make a big difference when you're trying to get fluids in quickly. So just to give you an idea, an 18 gauge needle that you just hang to gravity will infuse at about 70 cc's per minute. And if you squeeze that bag, you can get it to about 100 cc's per minute. A 16 gauge needle will go in under gravity at about 150 cc's per minute, but under pressure will more than double that rate to 350 cc's per minute. And one of the huge 14 gauge needles, just to gravity, will go in at about 250 cc's per minute, but under pressure will go up to about 400 cc's per minute. So if you've got an 18 gauge needle and you're squeezing the bag, it shouldn't take you more than 10 minutes to really get that liter in. And if you've got like a 14 gauge needle and you're squeezing the bag, you could get a liter in like 2.5 minutes. Remember that those electronic pumps are great for dosing medications, but they're totally inadequate for resuscitation. So if you're trying to get fluid into somebody quick and you set one of those pumps to its maximum rate at 999, remember that's 999 cc's per hour, not per minute. So it'll take you an hour to get a liter of fluid in, and that's just not good enough. And also remember, too, that if you ever can't get an IV in, you've always got the IO gun available. It takes 2 seconds to put one in, and that's a skill that you should be comfortable doing. Let's talk about vasopressors next. So we talked about 4 different vasopressors: norepinephrine, phenylephrine, epinephrine, and dopamine. And the big indication for vasopressors in shock is when the patient is hypotensive and you haven't been able to fix that with fluids yet. Which of those vasopressors you use depends on the type of shock that you're going to be looking at. So if you think you're looking at a hypovolemic picture, there probably isn't much role for any vasopressor. You should just really fill the tank back up. That person's probably already peripherally clamped down, so adding a vasopressor to do more of that isn't really going to help you. Now, if somebody's in distributive shock and their periphery is really vasodilated, you're going to want to select a vasopressor that's got a good alpha squeeze to try and bring that down to normal. So that usually means norepinephrine for sepsis and most other forms of distributive shock. The exception there is anaphylaxis, for which you're going to want to use epinephrine to get that extra beta activity in their lungs and protect their respiration. If you've got cardiogenic shock and the pump is broken, usually the first line is norepinephrine because it's got just enough contractility to really give the heart a little bit of a boost, but it doesn't have so much that you're going to run into problems with arrhythmias and that sort of thing. Now, if the patient's bradycardic, what you really need is some beta squeeze to punch up their heart rate a little bit. So in those cases, you're going to reach for epinephrine or for dopamine. If the pipes are blocked and you've got an obstruction somewhere, nobody really knows what the best vasopressor is to use. Really, we should just try and alleviate that obstruction, but until you do that, most of us are probably reaching for norepinephrine, really just because we're most familiar with it. Once you've decided on which vasopressor you're going to use, you'll have to decide on a dose next. And if you look at that last column there, there's always a range of acceptable doses that you can use. So how do you pick which dose? Well, the reality is you just use whatever dose you need to make sure that they get their blood pressure back up. And usually we're targeting a MAP, and a MAP of 65. MAP just stands for mean arterial blood pressure, and that's a blood pressure measurement that considers both the systolic and the diastolic values together. There is a formula that can help you figure that out. So MAP technically is equal to 1/3 the systolic pressure plus 2/3 of the diastolic pressure, but you don't ever really need to memorize that formula because just about every electronic blood pressure measurement is going to give you the MAP on the screen. So you'll see systolic at 120, diastolic at 80, and then the MAP at 89. And usually you want a MAP over 65. So you just hang the vasopressor, and then you just dial it up or dial it down however you really need to. And you try to hit some number between 2 and 20. There aren't really any maximum doses here. Some people say that you should stop around 10 mics per minute, and some people say you should stop around 30 mics per minute, and some people say you go as high as you need to go. But we know that there probably isn't a whole lot of benefit once you hit that sort of 20 mics per minute or equivalent. And once you do hit 20 mics per minute, you should kind of stop and reassess and think, what is it that we're missing here? Is this a person that's just drier than I thought and they need more fluid? Or could I be missing a pneumothorax or a PE or something like that? The usual approach here is to start low and then just titrate up. So start at 2, start at 4, and then just see what happens. If it's not enough, go up to 6, go up to 8, see what happens, and just keep cranking it up until you get what you need. Now, if a patient is really sick, like they're about to crash, about to lose their pulse, or maybe their blood pressure is so low that the machine is having a hard time picking up a number, you could just start high and then titrate down. So instead of using norepinephrine at 2 to 4 micrograms per minute, you could just hang it at 20 and then see what happens. Don't be afraid to use your vasopressors aggressively in this moment, because remember, they only last maybe a minute or two. So even if you were to overdose somebody on norepinephrine, you gave them 20 micrograms per minute and their blood pressure jumped up to like 200 systolic, you could just turn off the norepinephrine drip, and in a couple of minutes, that's going to go back to normal. And if a patient is so sick that you think they're about to crash, probably better that they have a couple of minutes of a blood pressure that's inappropriately high than just sit where they are with their blood pressure inappropriately low. I would also suggest too that if that really sick patient actually does crash, the first thing that you're going to do is push 1,000 micrograms of epinephrine, which is massively more than just the 20 mics per minute that you're going to give at the max dose of something like norepinephrine. So don't be afraid to use vasopressors if the patient's really sick and you're having trouble figuring out what their blood pressure is. There's been a lot of debate about the best way to get vasopressors into somebody's body, and traditionally these things have always been infused via a central line. Now, when I was an early resident, I don't think I knew what a central line actually was, but I think all you really need to know is that it's a really big, really long IV. So if you look at this picture, you'll see there's 2 purple ports that lead into a single IV catheter. And if you follow that IV catheter, you see that it's really, really long. So it goes all the way through those blood vessels and reaches into this person's IVC. And you can see the tip of that catheter right outside the right atrium. We think of the IVC as one of the central blood vessels, one of the really big ones that's just really close to a person's heart. And those central vessels we think are just more durable than the small peripheral vessels that we put most of our IVs in routinely. Because they're really close to the heart, you need a really long IV catheter to get in there. And simply by virtue of that catheter's length, it's going to be a lot less likely to be displaced or to shift around in any way. The worry with vasopressors in peripheral lines is that if a peripheral IV were to go interstitial, the vasopressor would then extravasate into some of the subcutaneous tissues, and that might result in some damage. And if a vasopressor infuses into the subcutaneous tissues, that could cause excessive vasoconstriction of some of the capillaries. And you think about those tiny little capillaries, they're already so small that if they were to vasoconstrict any more, the thought is that they could just cut off the blood flow to the tissues that they're supposed to go out to, which would obviously lead to reduced perfusion and could theoretically lead to some tissue necrosis. Now, in reality, this is extremely rare. This is the kind of thing that we really only hear about in case reports, and there's some debate now about how much we really need to even worry about this, especially given that some of these vasopressors will inject IM or subcutaneously on purpose. You think about how many lacerations you've repaired where you've used a little bit of epinephrine along with your lidocaine, or how many anaphylactic patients have received IM doses of 300 micrograms into their arm or into their leg. So we think that a large, reliable peripheral IV that's in a place where you can monitor it easily, so something that's not likely to go interstitial, and if it did, you'd be able to catch it pretty quickly, that's probably fine for a couple of hours, and it's probably fine even for a couple of days if you really had to. Now, I've filled your brain with info about vasopressors and fluids and types of shock, and I think it's very easy to feel overwhelmed in these cases because there's a lot of information to know here, and the patients are really sick. When you walk into the recess room and the patient looks terrible and the nurses are asking you what you want to do, this is a really intimidating situation. And I want to tell you that it's okay if you don't really know what's going on at the outset, because that's true for most of us. Figuring out the underlying etiology of a person's shock often takes time, and it often takes tests. Like sometimes you don't really know what's going on until somebody shows you a chest x-ray or an ECG, and then you're like, oh, that's what's happening. It's also really common for patients to have more than one problem at the same time. So that guy that's septic and in distributive shock is also vomiting and he's really dry at the same time. And so how do you approach that? I would suggest that it probably doesn't really matter as much as you think it does, because even if you knew what the underlying cause was, most of the definitive treatments don't work fast enough to really make as much of a difference. So If this is a septic case and the guy's got a pneumonia, I mean, yeah, he needs antibiotics as the definitive treatment, but you can't just stare at his blood pressure for like 24 hours until the antibiotics kick in. You're going to have to do something. So I would suggest that you do something now and then think about the underlying etiology later. Remember what ACLS taught you. Look at the rhythm. Is this a person that needs a cardioversion for a tachyarrhythmia? Or do they need pacing for a bradyarrhythmia? Or do you hear unilateral air entry on one side and maybe this is a person that needs a chest tube? Ask yourself, is there some reason that I shouldn't be giving fluids? Is there an obvious bleed here or do I hear signs of pulmonary edema? And you can figure out all of that really just looking at the patient and using your stethoscope. Remember that almost every patient can get some amount of fluids, so it's almost always a safe bet to start with 500 to 1,000 cc boluses and just keep doing that until you hit 2 to 3 liters, knowing that that might be how much it takes before you see a significant response. And if that doesn't work, your next move is going to be to start some kind of vasopressor. And if you don't really know exactly what kind of shock you're dealing with, I would just start with norepinephrine. You're going to be right most of the time. And if you're wrong, it's probably not going to make them significantly worse. The bottom line here is that you can't just stare at a low blood pressure. You're going to have to do something to fix the vitals. And if you can fix some of the vitals, then you'll buy yourself time to get more testing and look at the x-ray and maybe call a consultant to help figure out what's going on. So that's the end of this talk. I hope that we'll go into the sim lab next. We'll take all of this information and we'll try practicing it out. I'll see you then.